important? And how do you measure it, most importantly? We're also going to look at a case study in Portland, Oregon, which includes a pediatrician's perspective and a parent's perspective, which is perspectives we don't always have, and some other examples. And there'll be about 10 minutes at the end for questions, so you might want to jot them down if you have questions on the way. And I would just like to now go ahead and welcome Mary Minetti, who's going to talk about patient and family engagement. Welcome.
Thank you, Melissa, and good morning, everyone. Thank you so much for joining us at this early hour. I am happy to kind of launch this webinar and then turn it over to my colleagues who are doing some amazing work at the Portland Clinic. I wanted to start by just bringing your attention to the fact that there were not national agreed upon definitions of what patient engagement was before the Health Affairs article on patient engagement came out in 2013, and that was just, just a fairly short while ago. And in that issue, they talked across the continuum of healthcare and referred to patient engagement as a blockbuster drug, that it was really going to really address the ills of healthcare and help transform it and help lower costs and improve quality. And in that article, they talked about that engagement was really defined as an active partnership between individuals receiving care, their families, which families are critically important, especially in pediatrics, as well as clinicians, staff, and leaders to improve healthcare quality and the delivery of healthcare. So both at the individual level, but also at the system level. Next slide, please, Melissa. Prior to that time, often when individuals who talk about what patient engagement was, it spoke specifically about patient compliance, that engagement was really the patient doing what it was that the clinician was hoping was the best evidence, or that it, more recently we talk about patient adherence. Are they adhering to the medications that have been prescribed for them in the manner that they are? And both of those terminologies really don't get at the respectful relationship that we want to create with patients, that really recognizes their values, their preferences, their cultures, and really integrates that information into and with the evidence to come up with the best plan that is going to really meet everyone's needs in that situation. So it's really a shared decision-making kind of thing. Next slide, Melissa. So there are, and in this article and beyond, there have been other white papers and things that have been written that really talk about engagement at different levels. And today we're really talking about patient and family engagement at two levels, the direct care level and the organizational design and governance level. And so where we really want to get to is the right side of this slide, which is really on partnership and shared leadership. What happens often in healthcare is that it's a continuum, and that we work with people and we build skills and confidence and their sense of ownership of their own health, or parents, their ownership of their children's health. And it starts by consulting with them and giving information, and that's an important step to build confidence, to make sure that we're delivering that information in a way that's helpful. Involvement is that we really actively ask them questions and pull information from them to understand what's important to them. But eventually in direct care, we really want to get to the place where we're really co-creating plans that really are driven by those values. So direct care is one area where we engage patients and families. The other area, and we're going to talk about both areas today, is in organizational design and governance. So a number of practices survey their patients either using the CG CAPS or more informal surveys. And that's a great way to get information, but it's really one-directional, and often we can't engage in interaction to find information to try to understand what those scores mean. So the next level of involvement is really asking for input. And then when we really have a partnership model where we really respect and honor the lived experience of patients and family members, then we move to co-leading change. A recent white paper that came out of the National Academy of Medicine talked about patient and family engaged care. And the thing that they did, and the reason I'm bringing this to your attention, is they spent a lot of time looking at the evidence on a variety of levels, returning joy to practice, and those other things, outcomes and costs and those kinds of things. Next slide, Melissa. And what they found is that there is compelling evidence through looking at information over time that when we are engaged in authentic, meaningful partnerships with patients and families, that we get a better culture in our clinics, the joy of practice returns, we improve health, we reduce costs. And I encourage those of you that want to read more about it and really care about the evidence and want to get the latest and greatest to download that article. Next slide, please. One of the things that's true is that CMS is really trying to align their value-based purchasing and other payment programs with person and family engagement. What they did in December of this last year is they released a strategy that as an organization that they were really going to look at person and family engagement at all levels of their organization, but also require that in other places. So PFE is a primary driver in TCPI. It is involved in the quality payment program and the Medicaid patient engagement improvement activities. And so we're beginning to see the link as a result of them adopting this strategy. In fact, CMS has hired a notable international leader in patient and family engagement, Sue Sheridan, who is really looking at all of their systems and their programs to create incentives for practices to really embed these meaningful partnerships, especially in governance across the way. If you want to change to the next slide, please, Melissa. So as part of TCPI, many of you may be aware that there are some metrics that have been selected that they're asking you as a practice to report on in terms of adoption and as markers that you have implemented in a full way patient and family engagement. And the metric selection was done over a year's period of time. There were patient and family advocates, but there were also clinicians and community networks. And they created a framework for measuring PFE performance and really thought of it as that these 6 measures, and Melissa, you can change to the next slide, these 6 measures were really going to help guide practices to adopt things that really impact the patient and family care experience, but also help create systems within the clinics that are going to support person and family engagement. And they cover 3 areas: governance, point of care, and policies and procedures. So what they're going to be asking you to report on is whether or not you are planning or you currently do support patient and family voices through a PFAC, a board, or involving them in QI projects. At point of care, are you really training your staff around shared decision making? Melissa, you can go to the next slide so that people can see the questions that are being asked on the practice assessment tool that we are asking that you fill that out. In fact, over a number of practices, baselines have been created, and out of 30,000 practices, only about 700 have reported that they have implemented all of these measures: policies and procedures, shared decision making with training, using an e-tool, a patient portal, or other e-connectivity, whether practices are paying attention and measuring patient activation in some way, whether health literacy is forefront. All of these things impact the ability of the practice and the patient to create those meaningful partnerships, including supporting the patient and caregiver management of medications, which for many pediatric practices, that's not a large portion of your population, but rather a smaller portion of your population, children with extreme chronic conditions. However, it is important across all of the TCPI practices. So we tried, as we were creating these measures, to cover a breadth of areas where patient and family engagement is a key strategy and effort. Next slide, Melissa. One of the things that we also at the national level wanted to make available to you were tools that are practical tools that can assist you in implementing. And two tools that I want to bring to your attention and that Melissa and her practice advisors can make available to you are two documents, short, sweet, very practical documents. One on creating a culture of person and family engagement in healthcare that really engages your staff, builds on your team-based efforts. And the second, which was just recently released, is a short tool that you can work with patients and families that you identify as potential advisors in preparing them for the role of partnering with you that can be branded for your organization. So both of those tools are available to assist you in implementing the metrics that have been identified at a national level as important areas to attend to in order to create the foundation and the culture to create those meaningful partnerships. Next slide, Melissa. What I'd like to do is turn it over now to RJ Gillespie and Courtney Whitlock, who are going to talk about how they've taken this information, how they've created those relationships at the Portland Clinic, and give you an idea of what is possible. RJ?
Good morning, and thank you for having us on this webinar today. So as Mary said, I'm here with Courtney Whitlock, who is our parent partner. My name is RJ Gillespie. I have been a pediatrician with the Children's Clinic for 16 years. And what you're seeing are pictures of our 3 sites. So I wanted to give a little bit of background and history of our clinic. Between our 3 sites, we have a total of 30 providers. We have been around since 1911. Our founder, Joseph Bilderbach, was one of the first pediatricians in the Pacific Northwest. And so we are the oldest, I think, practice in the entire Pacific Northwest. Little known fact that the American Academy of Pediatrics can trace its origins back to a meeting of the American Medical Association section on the diseases of children that happened in Portland in June of 1929. Our founder actually was one of the people who was at that meeting and pushed for the formation of the American Academy of Pediatrics. So we see ourselves as having a long, proud history of innovation and of trying to take things to the next level in terms of how we deliver care. In 2009, our state started working on their own medical home standards called the Patient-Centered Primary Care Home Standards. And I sat on that first committee that sort of helped define what a medical home for pediatrics was supposed to look like. And pretty much right off the bat noticed that there wasn't a lot of standards around patient and family engagement or patient and family partnership. And so with the next round of revisions to the PCPCH program, that was one of the things that I advocated for. And so I think that our state is really looking across the board at how we do better partnerships with families. So we have in our clinic a strong quality improvement committee that has been going on for even longer. I think I've lost track of it. It's either 5 or 6 years, I think, at this point, which was part of our medical home transformations. And that's when we, as soon as we started, we looked for a parent partner to join us, and that's where Courtney comes in. So that's where we're coming from. We're going to talk a little bit. Courtney is going to introduce herself, and then we'll talk a little bit about what we're doing in our practice in terms of different ways that we're trying to partner with families. And then Courtney will talk about her perspective. So next slide.
Hello, thank you all for being here, and I'm enjoying the opportunity to speak with you all. I am the parent advisor for the clinic, and I have been here for doing, like RJ said, for like 5 or so years for the QI, and I also participated in the Medical Home Collaborative. It kind of got my interest in why it's important to start advocating from a family voice, family perspective, and gaining the resources that families need. I have a child with a chronic medical condition that we've had I've had a lot of challenges in the very beginning with her, but now that she's older, it's subsided to be more easily managed. But in the beginning, it was really hard with all the specialists and communication. I carried around with me for first year, so a binder with all the specialists and the doctor notes and everything, because it was really hard to have everybody kind of on the same communication path about my daughter's needs. So when RJ kind of approached me in this project, especially as my children's primary care pediatrician, I knew it was my chance to start utilizing my knowledge of being a parent with a child with special medical needs. And then on top of that, I have a degree in human development and family science. So really understanding the backbone of why it's important to engage families from different perspectives, culturally, economically, geographically, in bringing the resources and support that families need from their healthcare team, especially when they have children that are facing challenges, whether it's medical or behavioral. So I'm very excited to be here, and be happy to answer any and all questions you guys have afterwards. So next slide, please.
So as Mary was implying, you know, when we talk about some of these terms about patient compliance, it doesn't really capture what we're trying to do here. And even the idea of engaging families implies that families are not engaged to begin with. And I think that what we're trying to think about is really family professional partnerships. So how do we partner with families? And as Mary said, on multiple different levels, not only in the interaction between the provider and the patient or family, but also in the structure and governance and the policies that your clinic put together. So I'm going to talk about just 5 main areas that we've been working on. And the first really was the idea of putting a parent on our quality improvement team. Now this is part of our infrastructure. We've looked at adding adolescents as well, because I think that the perspective that teams can bring to how they're experiencing care, particularly as they're starting to transition to taking on the primary role. That's something we haven't done yet, but certainly something that we're still thinking about. But really, we felt like that was the most important and most critical part of our partnership journey, was to have parents come in and sit on one of our standing committees and have us get their perspective about how they're experiencing different aspects of the clinic. I think that whenever we're doing quality improvement, we always have this intention of what we're trying to do, but how that's actually experienced by the family remains a mystery to us unless we're willing to ask those questions of our parents and get that perspective. And there have been many times sitting in meetings where Courtney has mentioned very simple experiences about what it's like for a parent doing whatever it is that we're asking them to do, whether that's surveys or whether that's screening tools or whatever else. And so really understanding that parent perspective has brought a lot of insight and important information to that process. We have this phrase in quality improvement that says nothing about me without me, which really is describing what we want to try to accomplish in quality improvement, that we're not doing anything to a patient or a family without their involvement and their partnership and their input. The second is really about doing surveys to try to get more detailed information about the family experience. We use the CAPS CG PCMH, so the CAPS Clinics and Groups Patient-Centered Medical Home Survey. We've done that every other year. We just did our 3rd round last fall. And that gives you sort of broad stroke information, I think, about what patients are experiencing, from everything from the front desk and scheduling staff to the communication of the provider to how we're doing on self-management support. That tends to be one of the key areas that many practices don't do as well on as we'd like. So when I've looked at self-management support scores on the CAPS-CG across other practices, that's usually the lowest domain score of any of them. And I think one of the critical parts of shared decision-making that we'll talk about in a second. We've also had to do surveys, or wanted to do surveys, of smaller kind of focused areas that we need more information about. For example, we were noticing that even while we were open, we had a lot of our patients that were going to urgent cares or emergency rooms, and we really wanted to get an understanding of what the barrier, what the gap was. You know, were patients experiencing poor access? Were they not understanding our after-hours care? Were they not understanding our advice line availability or whatever? And so we did a survey that sort of looked through all of those experiences to find out where we were needing to improve, and found that really our advertising for our after-hours care was lacking. There were some aspects to people's use of the emergency room and urgent care that we couldn't control. For example, if they have an urgent care across the street from them and we're a half-mile away, then they would just rather go across the street. But certainly we were able to learn a lot about the patient experience by doing those kinds of surveys. And we've had different surveys throughout the years that looked at different issues around the clinic. And I think that that's a really important structured way of getting a whole lot of family feedback. Although generally when I look at the patient surveys, I might find an area of weakness and then want to dive further into that. And that's where things like focus groups come in, where you can get a group of patients together and ask them specific questions that's more qualitative about, you know, what their experiences are. And that's something that we've done on an ad hoc basis in our clinic for the last several years, where we'll bring a group of patients together and ask them a series of questions about different aspects of care. Our most recent was when we were trying to build our care coordination program, and we had a group of parents whose children experience special health needs come in and talk to us about their gaps in care, about the usefulness of shared care plans and how they would use and experience those. And we were able to build some shared care plans that the families felt would be useful based on that kind of feedback. So I think that the patient surveys and the focus groups often feed off of one another. The other thing that we've often done with our focus groups is if we have a response on a survey that we don't understand, then we can feed that back to our focus group and say, hey, you know, we don't really understand why people responded the way they did, and we might get a better understanding of how people interpret or read the questions by putting that in front of our focus groups. Back to that CAP survey, and again saying that one of the things that was weakest in our survey results was the idea of the shared decision making, or excuse me, shared decision making. And one of the questions on there is about whether or not the provider actually has talked to the patient or family about setting goals, either for wellness or for chronic disease management. And so that's something that we've been trying to incorporate into all of our well visits and in many of our chronic disease management visits. So if we're having a visit for ADHD or for asthma, really kind of getting the perspective of the parent or family in terms of what's important to them in the management of their own condition, and then helping to support them with ideas of how to accomplish those goals. And again, we've done that both with our well visits and with many of our different chronic disease management visits. I very recently had an appointment just a couple weeks ago of a 19-year-old who came in for a well visit and set goals visit, which to me, at first I was a little surprised at the idea of somebody making an appointment for setting goals. But when he came in, he said, you know, last year you talked to me about my goals, and I feel like I need a little bit more focus in terms of how do I resist peer pressure, you know, and he said that he had maybe 10% of his friends who didn't smoke marijuana, and he wanted me to talk through what his goals for his, you know, college years should be, and how he would avoid those kinds of triggers. And so really it spoke to the idea that the patients and families respond very well to the idea of helping them set goals. I have another kid who, whenever he comes in for his ADHD med checks, the conversation in the car on the way to the office between the mom and her son is, what are you going to set for your goal today? And have you been accomplishing the goal that you set last time? So that this is something that really has been, I think, an important culture shift. And one of the things that I think makes medicine far more effective, rather than me telling somebody what they should be doing or what they should be changing, it's really the essence of motivational interviewing, that you're trying to figure out what is important to the patient or family, figure out what those barriers are to accomplishing their own goals, and then helping them to line up what they want to do. You know, the last thing that we're still in exploration about, and that we're trying to figure out how to make work, is the idea of a peer navigator or a peer support specialist. And this would be the idea of having a parent actually as part of your care coordination team. So rather than having your care coordinators just be RNs or other medical professionals like social workers, that you have peers for these families who help them to connect with resources and help them to identify what their specific resource needs are. As soon as we can figure out the finances of it, there are some Medicaid codes that can be used to bill for services if peer navigators have specific training. That's something that we're hoping to add into our office. And what we find oftentimes is that parents have a little bit of reluctance of really opening up to professionals when you're asking about what's not going well. Whereas it's a little bit easier to communicate with a peer about what your specific needs are. I think that there's a little bit of a hierarchical barrier between parents and providers sometimes that we need to figure out how to break. And certainly having parents on your medical team to help assess family needs is one way to kind of come to overcome that. So those are the things that we're working on specifically in our practice. So I'm going to turn it back over to Courtney for her perspective. So next slide, please.
All right, so I'm going to follow up some with what RJ was saying on the next couple of slides, but I want to start off by just introducing the why I became a parent partner. And just from my own challenges, like I said, having my daughter was 2 when she was diagnosed with her significant medical challenges, and having to kind of navigate that system independently was very stressful and hard, especially since I was a single parent. So I, during a visit, came and visited with RJ, and it was just one of those moments where I knew that he understood what I was saying, what I was advocating for, and where our partnership started as far as I having the voice to advocate for the support system that parents need for children that are going through either medical conditions or behavioral conditions, and the challenges that both the child and the families go through when we have to deal with those. And then I really like that I get to integrate what is in the best interest of the family and the children. I think I have like I said, my background is in family development, and so I want to make sure that it's just not my perspective that is being introduced, but an overall understanding from where the barriers are with families and why it's important to have those support systems integrated into practices, because often the practices can be the first line of resources or defense for families when they're in a state of kind of upheaval, when either medical or behavioral changes are integrated into the family. And with the work that I did with one of the collaboratives, I really found the significant importance of patient-centered care. Really having that team feeling that I can call my pediatrician, I can call my specialist, and they're communicating through chart notes or brief conversations about the support and care that my child's getting, and that it's not them that doesn't always leads the care for the family needs. It's the patient and the parents that are making sure that everything is integrated into what's going to work for that family, along with their beliefs and the family styles, access to the care and how quickly we get there. So really wanting to make a voice be heard and why it's important to bring in patient-centered care into practices. Also wanted to show a contribution to how to improve where like RJ was saying, that perspective where sometimes physicians don't always understand how it can be as challenging just getting a child in the car to have to leave to go to the doctor. It's not like, oh, hey, we're going to go and we're going to do this. Sometimes behaviorally or medically, it's very hard to get a child to cooperate, and how stressful that is in order to go somewhere, especially if it has to do with something that a child knows that there might be harm done. Or test or anything like that. So sometimes that understanding like why we might be a few minutes late and appreciate that instead of being disciplined for, oh, you're 15 minutes late, realizing that no, we understand you have these challenges. Excuse me. And then I guess lastly to really be actively involved in changing and having a voice in healthcare and policy changes until we start utilizing what our voices to change what needs to be done. They're just going to sit there and not be an important concept to really understand why families can be so challenged with children that are having chronic conditions or behavioral conditions. And it's not just often a phase of that family's life, it's a longevity of the family's life that they have to deal with these challenges. And so having that really integrated into healthcare and policies is an important reason why I became a parent partner. All right, so next slide, please. And then so some of the stuff that I've contributed to just being in the QI committee and working with RJ over the last 5.5, 6 years going on. Most of my stuff has been with the quality improvement, where like RJ had mentioned, going over making sure that surveys were verbalized to engage families and wanting to participate, making sure that they felt like this was an important aspect to bringing into their input was important, and not just another thing to put on families to gain information, to make sure that the surveys and the questions are really being heard from the clinic, and why they're really important in making sure that the healthcare, their healthcare and the clinic practice is giving them the best quality of care that when they come into the clinic. Additionally, in the QI, I've really encouraged support for the mental health services. I have a part of my degree program was in psychology, and so really understanding bringing in mental health support, especially for families that have children with chronic conditions where mental health seems to be can be a challenging aspect, because they understand that they're not as similar as their peers, and as they start getting into the adolescent times, they understand that they have more challenges, which becomes mentally challenging for children. So making sure that there's accesses or supports to mental health or behavioral health programs. And then really advocating, like piggybacking on what RJ was saying about having the family or peer support specialist, family navigator. What he initially introduced was why it's important to speak to a peer, a family representative that can understand, like, yeah, I have a child that has this condition, so I do understand these, because there is that hierarchy that's really hard to break down, where families sometimes come in and they feel like they have to do what the doctor says, they have to do what the nurse says, because they don't have much of a choice in that. But when you kind of come in on a level playing field saying, no, you do have choices, these are kind of other ways to think about it, the care for the child or the patient is much more readily accessible, or being able to execute much better, because it's being met by a support system that's not just within the medical team, but as a peer support specialist. And then also, RJ and I worked on quite a few collaboratives together. My first one was the OPIP, which really introduced the Medical Home Learning Collaborative, and why the QI committee was introduced into the Children's Clinic and why I became involved in it. I've done work with the American Academy of Pediatrics, again, doing quality improvement stuff. And most recent one was with Johns Hopkins University and their Pediatric Integrative Care Collaborative, bringing in family voice and family perspective, because partnership is what matters. It's very important to get not just what we perceive as, from in a medical perspective, as the best care that we want, but really understanding how to involve the parents and the families from the perspective of what will best work from them, understanding their weaknesses, helping them grow with their strengths and stuff like that. So, but I'll be happy to answer any other questions, more direct questions at the end, but thank you for letting me speak with you. RJ, do you have anything else to follow up on?
No, I think that's it. So turn it back over to Mary.
Great, thanks. So what I want to do really quickly, and still leave plenty of time for questions, obviously RJ and Courtney have worked together for a while, and they have really, over a period of time, really developed some great ways to collaborate. I want to show you some other organizations that have collaborated with patients and families that can give you some ideas of what else might be possible. Next slide. So one of the things that's really an easy, quick win is to get some patients and parents together, and this is an example of a pediatric waiting room clinic that was before. It's nice, but afterwards they walked through it with parents and with adolescents and talked about, is it creating the welcoming messages? Is it reducing anxiety when you're coming into this space? Courtney spoke very clearly about kids can kind of not want to go to the doctor. And so very quickly, without a lot of money, they got some really good ideas from their parent and patient partners and changed the way that the look and feel of that initial interaction. Another example is at the Petaluma Health Center. They used some of their patient partners to use an iPad like this and drill down. RJ talked about that they drilled down to get more information. So they did surveys in the waiting room, and patient partners would sit with patients and family members saying, you know, are you feeling like you can share some information? I come here to the clinic, and the ability to be able to interact patient to patient, parent to parent, really breaks down some barriers. Another example, next slide please, Melissa, is at the Cambridge Health Alliance. They wanted to do some work on care plans, and what they realized in working with individuals who attended their clinics or parents who brought their kids to the clinic was that when we think about, when we're healthcare professionals, our whole day is consumed with being at the clinic and doing things. But when we talk to people who are receiving care, it's a very small part of their day. And so what we may think of as not much of a treatment burden in terms of a care plan may be a huge treatment burden. And so having that is really important, understanding that perspective. Next slide, please. And so they worked with their individuals, hit the slide a couple times so that the care plans came into view. So what they did is they worked with their parent and patient partners to develop care plans. Hit it one more time, Melissa, so that they could provide their patients with examples that were easy to read, that were using health literacy topics and those kinds of things, so that they could make care plans that were relevant to them. And so they worked with their advisory council to work on that, and then they created a template that they could then fill in different ways. And if you notice before the slide changed, one was related to diabetes, and they specifically with that one worked with patients and families who were experiencing that chronic condition so that it was relevant. Next slide. So I want to talk a little bit about Essentia Health in Minnesota, because they are very visible and engaging in terms of, this is the pictures of those women being parent and patient partners, was their campaign to very transparently say to their community that we want to partner with patients and families to improve the care. And so Gordy is a pediatrician, and that's his team. And he developed a patient and family advisory council. It wasn't huge. It was 5 members who met on a regular basis. Next slide, Melissa. And his advisors contributed a number of ideas. One of the things that they wanted to do as part of their medical home implementation was improve access. And so they worked with patients or parents of kids who were very complex medical conditions and created an access line that was special just for them to call, so that it went directly to somebody so that they could get those kids in as quickly as possible, because it could make the difference between them being able to stay at home or ending up being hospitalized. They also used their patient and parent partners to share stories with staff and clinicians as part of the education and orientation of new staff. They, too, involved them in development of care plans. But the interesting thing that they also did is that they brought their advisory council together to help identify what would help move patient experience scores toward always. Because often they were getting 7s and 8s, but not always on those surveys. And the nuance of what would move somebody from a very high score but not the very top score was something that the staff were unable to identify because they didn't have that lived experience. And of course they had to talk with lots of patients and parents to understand that, because it isn't one size fits all, but it helped them be able to make some changes to their practice. Next slide, please. We talked about patient activation as being really important. Patient activation is the confidence, skills, and knowledge that somebody brings to managing a health condition. And we really recommend that in order to create those meaningful relationships, you have to start where somebody's at and help build confidence and skills. And so being able to identify what's most important to somebody and then identify small steps to get there so that they experience some success is really important. And here's an example of some questions that you can ask that can help you be able to begin to understand what's important to people. And if you're talking about scales of 0 to 10, once they answer the question, well, I'm a 5 on this scale, when you probe what would have made it be lower, what could have made it be higher in terms of confidence, it gives you some guidance as a clinician or as a care coordinator about what are some interventions or supports that you can provide to somebody to build their activation. Next slide, please. So we talk about e-tool use and as being one of the metrics for PFE and the TCPI project, and Open Notes is the next level of e-tool use to move beyond the patient portal that only just shows medication lists and actually opens up the note from the doctor. And there's all kinds of evidence that shows that when you embrace Open Notes, that patients and family members really understand and are reinforced to be more active members of the care team. So that's something that we really encourage organizations to look at as they're, if they've already implemented patient portals, are there ways that they can open up more of the record transparently so that that partnership can become more bi-directional. Next slide, please. Some organizations, depending on their size, don't yet have electronic medical records, but there are other resources out there. And I wanted to share with you How's Your Health, which is a way for you to get feedback from your patients prior to their visits, and was developed by John Wasserman of Dartmouth. However, texting sometimes is a great way to connect, and I wanted to share an example in one practice, one specialty practice, where after a patient completed their visit for the day, within 3 hours they got a text message that was set up to go to them and said, we want to know how this visit went to you, and it directed them to a secure website where they could answer just 3 questions, and then a person at the clinic would review those questions and right away could reach out with a phone call to somebody if there was some concerns about their visit or they had some questions or were confused. And so it's another way to use an e-tool, in a sense, people's smartphones, to connect with them maybe in a way that you haven't thought about before. Next slide, please. Health literacy is a big issue, and we talked about that as being one of the metrics. And these are some tip sheets that were developed by parents for parents to increase their understanding of their role as a partner with their healthcare professional, and really focused on the collaborative relationship, and really was something that was done in at the Alberta Children's Hospital in their pediatric clinics as a way to really share information in ways that were engaging. Parents care very much for their kids, but sometimes when they are experiencing new medical conditions, it can be overwhelming, and so parent-to-parent advice can be very reassuring, and it's an example of peer support, not to the level that the Portland Clinic is going to, but it's a way to address a number of things. Next slide, please. RJ talked about some of the mini surveys they did to understand why people were going to urgent care or to the hospital when they could be coming to the clinic. This next example is a poster that was developed in partnership with patients and families to encourage people to utilize the primary care site, which was often for many conditions more appropriate than going to urgent care or to the busy emergency department. And that useful information can really help improve someone's health literacy, as it would be, because health literacy just isn't the ability to read and write and understand medical information, but it's also the ability to know how to navigate the healthcare system. And appropriate navigation is around making sure that you get the right service at the right place and in the right setting. Next slide, please. Involving patients and families to give feedback on your patient portal is an example in the next slide of Providence Medical Group, which is also in the Portland area, where they had their advisors look at the patient portal and give feedback about how to make it more useful. And they focused primarily on the fact that it was 5 clicks to get to somebody's medication list, and they felt like that should be on the front page of the patient portal so that people could access that information quickly and give feedback if there were any changes to their medications and how they were taking them. They felt like that was a safety issue. And quite frankly, a lot of people won't go 5 clicks to get to something. And so if you want to support people in their medication self-management, what Providence learned from their feedback from their advisors was make it easily accessible. Next slide, please. RJ talked about the fact that they're at the Portland Clinic thinking about getting adolescents involved, and I wanted to bring to your attention the Adolescent Health Initiative, because they have engaged in Michigan adolescents in a really profound way, and they've developed a number of videos with adolescents, some on LGBT issues and a variety of issues. And one of the things that it does is, one is it raises awareness of healthcare professionals and others in terms of adolescents' perspective, but it's also really great educational and conversation videos that can assist with staff education as well as working with advisors. And so I wanted to bring that to people's attention as a resource if you're thinking about, and I hope you are, engaging adolescents as partners both in care and in governance. Next slide, please. Peace Health, which is in Eugene, Oregon, their advisors went to a community meeting on Quality Improvement 101 that was put on by an organization, and they came back and realized that it may not be as obvious to patients and families about how important they are as members of the care team. And they, in partnership with the organization and some community efforts, created a series of videos on how to improve safety and what your role is in medical visits and those kinds of things. And that was a great example of advisors really co-designing and co-leading this development of this video for education for new patients and families to PeaceHealth. Next slide, please. Often organizations are concerned about well-child visits, and so there are some ideas related to ways that you can increase the engagement of patients and families, and shared medical appointments for well-child visits is an approach that's been proven to be successful in many areas. I just wanted to bring that to your attention. But in the interest of time, let's, Melissa, go through to the next couple slides. I want to just bring to your attention a couple additional resources. The point of our conversation with you really is about how important partnership really is. And we want to make sure that you have the resources necessary. So I wanted to bring to your attention the website, the Patient-Centered Primary Care Support and Alignment Network set of resources. So if you're interested in a patient advisory council or how to do focus groups or how you might do some of these metrics in more detail to really up your game in terms of your engagement efforts and partnership with patients and families, we recommend that you check out this website. There are a number of support resource tools. Next slide, Melissa, there. Also, we encourage you, if you're interested, to check out the resources that are available at the Institute for Patient and Family-Centered Care. So these are some of the resources that you can see and get from your practice facilitators through Melissa. But at the Institute for Patient and Family-Centered Care, we have a PFAC network where those people who are trying to create great partnerships with patients and families and other advisors can share information across the nation. And we also have access to best practices about peer navigation and support. So there are a lot of resources there. So without further ado, I'm going to turn it over to Melissa so that if there are some questions, we can respond to them, especially RJ and Courtney, who are on the front lines and may have some real practical information that you want to know more about. Melissa?
Great. So I'm just going to keep track. If you have a question, you can type it in the chat box. I believe all the participants are muted, so feel free. This is your opportunity to ask Courtney or RJ or Mary any questions that you have.
Hey, Melissa.
Yeah.
Can you hear me?
Oh, I can hear you. Look at that. Okay. Yeah.
Well, this is Karen, and I'm on the phone. I'm not actually on the website.
Okay.
I've been listening to it. So I just wanted to let Courtney and the doctor know that WSU is actually working on a program, and they got a grant for the peer participation thing that they were talking about. And CMAR is actually working with it in Seattle. I don't know if that'll help them with getting funding to help their clinic or not, but it might be something to look at, or maybe contact WSU and find out from them. I can actually somehow, I have a pamphlet on what it's about and like that, if there's some way I could get it to them.
Well, unfortunately, we're in Oregon, so I don't know if we would be able to apply for a Washington State grant, but we have been working with our Medicaid agency here to figure out how to make that happen. And part of the process for peer navigators, at least in Oregon, is our Oregon Family Support Network offers a training that makes someone a certified peer navigator, essentially, that would make them able to bill under Medicaid. So it's mostly just been a slow process, because part of what we're doing at the same time is we've been doing our behavioral health integration and replacing our administration and redoing our governance. So it's something that's on our list to do, but just is slow moving because of everything else that's going on. We're under constant change in this practice as we're trying to improve everything that we're doing. So I appreciate the input, though. It would be great if some of our universities would do that kind of work too.
Yeah, that's great. We have another question, which is that our parent advisors paid for their time for Courtney and Dr. Gillespie?
We recommend it very highly. I don't think it's fair for staff members to be paid to go to meetings, or providers to be paid to go to meetings, or to have that part of their duties without having some compensation for the family. That said, I think Courtney has refused our compensation for a lot of the years, but typically $20 to $25 an hour would be the standard for paying parent advisors.
Okay.
Yeah, I for a long time haven't accepted it just because I feel a lot of it was associated with my learning. I was doing it when I was going through school, and it just to me, it wasn't about a financial incentive. I got more out of it because I created or developed more of a connection without making it feel like I was just there for the incentive. I wanted to make sure that the committees that I worked on knew that I was truly invested, that my interest is there for the overall betterment of for the clinic. And up to this point, I haven't really needed any compensation. I've really, really enjoyed what I'm doing, and I feel actually more rewarded doing it without having the incentive behind it. So but most compensations are greatly appreciated, especially if they have small children or they have to hire somebody to watch the kids while they're in the meetings or something like that. And other people might be more motivated by that, but that wasn't my initial engagement with it.
Okay.
So, nationally, this is Mary, and nationally what I would say is that there is a wide range of whether or not individuals are compensated, and generally for most patient and family advisory opportunities, it is volunteer. However, you want the advisors that you're working with, especially in councils or on groups, to represent the population you serve, and so you want to be sure and ask questions about what might prevent somebody from participating. And I think Courtney kind of landed on that a little bit, which is if mileage reimbursement or bus tokens or childcare is needed in order to create the opportunity for people to be able to fully participate, we really recommend that you look at that. And the level of compensation would vary depending on, like if somebody's hired as a peer support or navigator, they have the parent perspective, but the level of involvement and requirement is much different. So often the higher level the involvement, the more likelihood that compensation is going to be needed and should be recognized.
Mm-hmm. So we have another question, which is that some clinics maybe consider having a patient survey as having a meaningful patient-family engagement. Can you talk the way engagement is measured to encourage practices to move to deeper engagement? And how did you first recruit? Oh, sorry, that's not, and then we have another question after that.
I think from my perspective, the times that we've gotten patient surveys back, oftentimes we'll have a result and we'll look at it and we'll be able to throw our interpretation on it, but what the patients and families actually read and meant when they answered the question might be different than what we interpreted. And there are often times when, we'll have a survey question and the answer is that no, we didn't do that, and our answer is but yes, we did. So how is it that family didn't experience what they were supposed to experience? In our last patient survey, for example, one of the things that we're doing clinically is we're assessing parents for their adverse childhood experiences, which is a whole nother long story. And so we added some questions into our patient survey just to see what the patient experience was like. And I got some comments back from this one mother who had an absolutely horrible triggering experience from it. And I didn't understand how that could be based on our process. And out of thousands of patients who have experienced this screening, this mom had an awful time with it. And so I called her. I got her permission to have a conversation about it. She actually sent me her email, and then we set up a phone call. And there were so many steps in the process that had fallen apart for her. She didn't get the cover letter with the explanation of what the screening tool was about. When her provider was talking to her about the survey and she raised some concerns, the response was, well, I'll pass that on, but not actually addressing the concern up front, and so not recognizing that the mom was feeling traumatized by it, and so there was a lack of empathy. There were just so many things that went wrong in the process for that one mom. Now, you can have the best system in the world for most of the moms, but if this one has a bad experience, that's something that you really need to understand the answer for. And so oftentimes, again, if we think we're doing something, but somebody didn't experience that, that may come out in the survey. And I think that kind of going the next level and understanding the gap, like for those people where things didn't go right, why not? And that tells you a lot about your system. And you know, so I can understand now that when one of our front desk staff people was copying the survey because they were out of copies, they took a shortcut and left off the cover letter. That's not okay, and she didn't understand what that cover letter was there for. So I can sort of see where the system pieces fall apart. So just doing the survey and reading the results doesn't really always get you the depth of information that you need. So again, I really think that all of the useful information in quality improvement is in the gap. So when you didn't achieve what you had intended to, so the kid who didn't get the developmental screen, the parent who had a bad experience with the front office staff, why did that happen, and what can we do systematically to fix those kind of problems and prevent those kind of problems? That's where all the really rich, I think, information and quality improvement comes from. So you don't get that just from the paper survey. It really takes a deeper dive. I don't know if that answers the question. I hope so.
So we have another question, which is, how did you first recruit parents? Did you just ask likely candidates, or do you have an actual process for doing that?
So there is a process that's recommended, like our family-to-family support networks through the Oregon Center for Children and Youth with Special Health Needs has a manual on recruiting parents and families. I can forward some of that information to people if they're interested, but we started by kind of identifying what sorts of traits we were looking for. For us, I think it was important to have, particularly for our family advisory group, when we were talking about care coordination, we really needed to have, for example, parents who had kids with special health needs. We needed to have parents who felt comfortable speaking up in groups. And so we asked a lot of the providers, like, who would you recommend? And I think most providers can say, oh, I can think of one or two parents who would be really good in that role, for various reasons. And so for me, having worked with Courtney for years as a patient, I knew that she had some of those characteristics that we were looking for. But I think first is sort of identifying what the traits and characteristics are that you're looking for, and then trying to match families to that, again, by asking providers usually. We also did put some kind of recruitment materials up in the waiting room and on our website and our Facebook, just to say, hey, we're doing this. So anybody who saw that and identified that as something that they're interested in doing would have the opportunity. So if they didn't immediately jump to the provider's mind, then we were able to still capture some of those families as well, people who are really interested. And I think that, part of the fear is that, you want to have families, people tend to want to have families that are just going to agree with what we're doing and say how great we're doing, but there's so much value in, again, the parents who have had a bad experience and really exploring that. So people who are critical of us actually add so much value to what we're trying to do, because we want to be the best. And so if somebody has those critiques, then we want to hear that. So I think we found some of those families, again, just by posting some recruitment materials, because they had something to say and they needed a space to say it in. So those were kind of the two big methods, I think.
Okay, and then going off of that question, when is the best time for the staff parent advisory meetings, have you found?
I think that depends. We ran most of our focus groups during the day, like when kids are in school. We do our quality improvement meetings in the morning, which is not ideal because, parents are still trying to get their kids off to school, but it is the time that the staff and providers are able to meet as well. So I think that sort of depends a little bit on who you recruit and what the purpose of the group is. Courtney has been able to have a much more flexible schedule and shows up for morning meetings more than some of the other committee members, honestly. and so that's been helpful. But like for our family focus groups and advisory councils, those have been during the day. So we have a staff member who mans that, and then their kids are usually at school when that's happening. And we have had some of our focus groups where people bring their kids and their infants in arms or toddlers or whatever, and being a pediatric office, we're just kind of like, whatever you got to do, it's fine. We love kids, so even if they're sitting squawking in a meeting, that's fine with us.
Great. That's great. Well, in the interest of time, we are a little bit over, so I thank everybody for tuning in. Ray and Courtney and Mary, is there a way that people can contact you if they have more specific questions that they want to ask?
Mary, have you shared our emails? I mean, I'm happy to have emails shared.
I can send that information to you. It's not on our slide deck. My phone number and my email is, so maybe and I'm assuming people get a copy of our slide deck. So
yeah,
perhaps what could happen is if people just email me the question or the issue, I can forward it on to Courtney and RJ in the short term, if you can't wait. And then Melissa, I will send you Courtney's and RJ's emails.
Great.
So you have it.
Great. So what I will do, wonderful. So what I'll do then is if you guys are comfortable is everyone who participated, I'll just send you your contact info, and that way if there's more specific questions or if you are interested in doing this similarly in your clinic, you can have those resources, and I'll send you the slides as well. All right, this has been really, really wonderful, and you guys are doing amazing work. So I really appreciate you taking the time to have this webinar, and appreciate all the work that you're doing. And thank you all for participating in this webinar. I appreciate it.
Thank you.
Thank you.
Thank you.
Thank you. Have a wonderful day, everyone. Bye.
Bye-bye.